Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs and the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Hello. Welcome back to another episode of the Unreal Results podcast. Here we are. Another day, another episode. In full disclosure, I've been very unmotivated to work on business stuff. Don't know why. Just that's the way it goes sometimes, I think, for everyone. Well, at least for me. I can't speak for everyone. But it is funny because it's not that I don't have a lot to say. I have a lot to say about the industry. I have a lot to say about the body, rehab, manual therapy, working with clients, etc. It's just sometimes the constant creation of content for social media and podcasts and email lists and all the things, it just gets to be a lot. And sometimes I'm like, I just wish I could do a simpler life and just treat patients and live my life. Which I do treat patients a lot, and there's nothing wrong with that. I love that life. But then I'm like, but also I have so much to share, and I'm out here trying to change the world, trying to change the industry, trying to get the industry out of this mediocrity, this status quo, this missing of the red flag in itself of people not getting better, the red flag of mediocrity. So it's also as much as I get tired and I'm lose motivation, I'm also well, I can't stop. I don't want to stop. So here we are, showing up anyways. Oh, the funny thing about teaching and about social media, because at the end of the day, social media, all those things are teaching. And whether we're teaching anyone, fellow clinicians, children, teenagers, college students, our patients, no matter the level of our patients, our family members. The funny thing about teaching is we have to repeat ourselves over and over and over again. And I've talked about this before. I am blessed with a brain that absorbs information really well and doesn't have to hear it. I don't want to say doesn't have to hear it more than once, because I have to hear it more than once too, but I retain a lot of information once I hear it. I don't need as many repetitions as I think a lot of other people do. So when I'm teaching, that means sometimes I go to teach something, I'm like, well, I already taught that. Why would I reteach it? And it really is one of those things where it's no, I got to reteach it. I got to say it again. I got to say it again in a different way, from a new perspective. So it's I can't worry about repeating myself. And the podcast, it's been around for a few years now, and I've been fairly consistent. I'd say obviously I miss weeks here and there, but for the most part, I've grinded out a new episode every week for 2-3 years. And sometimes I'm there's only so much I can talk about. So inevitably, some of the episodes are going to be on topics I already talked about. But I think I think it's important to hear. And so that's what today is. like today's going to be an episode that I share about a case to get a point across. And I was looking through all of the archive of the past episodes, and in 2024, I had 2 episodes on similar subjects, and I'll make sure that Joe links those in the show notes. But I'm also like, well, this is still important to say. So without further ado, we're going to talk about how often clients come in complaining of back pain, and when you ask them to point to where their back hurts, it's their sacrum. And more times than not, when someone has pain on their sacrum, it is driven by the viscera, and specifically urogenital organs at the viscera. So this person specifically came to see me, and he is one of my buds candidates, so a Navy SEAL candidate, and he's been having some back pain that he hasn't been able to, train his way out of, or like stretch and mobility wise. So one of the reasons I love working with these buds guys is because they're just like my athletes in terms of like they'll do a bunch of things to try to help themselves, in addition to see practitioners to try to help them, and they don't settle for mediocrity. And so that's exactly what the case is for him. Like, he's gone to PT, he's gone to doctors, nothing's really come up. Exercises haven't really helped. Mobility stuff hasn't helped. His mobility is actually great. I looked at him move and I was like, honestly, I could see how somebody could watch you move and be like, you don't have a mobility issue. We're going to get a little bit more specific. I was like, but yeah, I see how you could go into traditional physical therapy and not get great results, and then also not feel like the clinician maybe like is treating you uniquely, right? Like, probably feels a lot like a cookie cutter type of treatment. And he was like 100%. And then so often, like, they give people exercises, and these people are already exercising a lot and doing all the strengthening things, and they're not weak. They're rarely weak. The story that clinicians give clients about glute weakness, hip weakness, quad weakness, and core weakness is just that. It's a story that is not accurate. So anyways, I'm asking him questions, but once he points to where he hurts, that's the first, obviously I'm doing the LTAP on him, right? The locator test assessment protocol. I'm seeing where the body is taking me. But also, we have to remember that the locator test assessment protocol, even though it's a really important part of my assessment and it helps me to figure out where to go for treatment, and sometimes uncovers deeper drivers to the pain or the injury or whatever's going on, it is not like a direct A plus B equals C, right? So basically the LTAP is telling me, presenting to me the person's first layer, right? Like I like the onion principle or Shrek principle is like, this is the first layer that the body is presenting to me that the body is protecting. And when it's in a protection pattern around something that may or may not be related to the thing that hurts, it's preventing the body from shifting into the self-healing capabilities it has to make the thing that hurts feel better. And so, so it's like, I still need to do my due diligence in being like, what brings you in today? And then before I do treatment, where the body's directed me, doing a thorough diagnostic exam and questioning on that. And so, that's what I did. So I do the LTAP, and the LTAP was taking me to his like right lower leg. And I was like, what brings you in today? And he was like, back pain. And I was like, okay, tell me about your back pain. And he pointed to it, and I was like, okay, well, that's your sacrum, which Doesn't mean a difference to you. Like, it's still the back of your body, lower down in your torso. It's still back pain. But to me, that triggers a whole different series of questions than when they're pointing to their lumbar spine, or when they're pointing to their mid back, or when they're pointing to their leg and like sciatica type pain, right? So once he pointed to his sacrum, I was like, oh, okay, there is a visceral driver to this. Interesting, right? That the LTAP actually didn't direct me to his viscera right out of the gate. It directed me to the lower extremity on the right side, which means it's peripheral neurovascular entrapment, or the SI joint itself there. And I did further, using the LTAP. It was not the SI joint itself. It was down in his lower leg is where the protection pattern was. And so I was like, okay, so pain's on your sacrum. And I was like, for me, that is a trigger of like, well, this has a visceral driver. Pain on the sacrum always has a visceral driver for men and women. And so I was like, okay, I have some questions for you that are going to maybe feel a little out of nowhere because maybe nobody's even asked you these things. I was like, and I explained to him, I was like, most of the time when we have pain on our sacrum, it actually is often coming from visceral organs, the urogenital organs. So I'd like to ask you questions about the urogenital organs and the other organs of the pelvis. And so I was like, tell me about your bowel movements. Tell me about your bowel movements for the last couple months. Cause I'm like, how long has this been going on for? And he's like, oh, like month and a half or so. And I was like, okay. And so we're talking about that. And then I'm like, tell me about peeing. Like, are you able to, do you have any pain when you pee? Are you able to, how frequently do you pee? When you pee, do you feel like you go all the way? Like, are you able to stop? Do you have any incontinence issues? And then he was like, oh, actually, yeah, I do. And I was like, oh, interesting. Tell me more about that. And so we talked about that, and he was like, actually, so about a month and a half ago, I think I passed a kidney stone. And according to what I read on the internet, like it was exactly the feelings of passing a kidney stone. And then all of a sudden it was gone, which is like often like, yeah, when you pass a stone, whether it's a kidney stone or a gallstone, once it's passed, a lot of the pain and discomfort just goes away. And so I was like, oh, okay, that's really interesting. And he was like, yeah, now that I say that, like that was right around when this all started. And I was like, okay, there you go. And in case you didn't listen to one of the last podcast episodes, I'll have Joe link that in the show notes too. Like the questions that you need to ask people to set expectations. I mentioned in that podcast how sometimes when you ask the right questions, the athlete or the client ends up telling you exactly what's going on. This is a really good example of that. Is I asked the right question, and then all of a sudden he was like, oh shoot, yeah, my back pain actually started right after that. And I was like, isn't that interesting? Okay, so you think you passed a kidney stone, and then since then you've had back pain, and then two, as I continue to ask him questions about urogenital organ stuff and leg things, he proceeds to tell me not only does he has since then has had incontinence, but he's having sensory issues in that area, erectile issues like pain down his leg, numbness, temperature regulation issues, like so many more physiological symptoms than I probably would have caught on a normal subjective history. And that's all because of knowing that when someone has pain on their sacrum, it's almost always driven by the viscera. Now, here's the thing. And I told him, I was like, listen, like some of this stuff is very much out of my scope. And well, not my scope, maybe not my scope, a little bit out of my scope, but definitely out of my wheelhouse. It's definitely out of my wheelhouse. A lot of these more functional complaints or like physiological complaints, I am like, I don't know where to start. But here's the thing. They're concerning, very concerning to me. I was like, I know you didn't think you were coming to me to talk about these things. I'm like, but these are the things that are related to your daily living, your quality of life, and your quality of life through your whole lifespan, not just you getting through buds. And he was like, oh yeah, no, I understand. I was like, so I'm gonna do what I always do. I'm gonna treat you the way in the sequence that your body presents to me, and I'm going to gather all the orthopedic and biomechanical data that I think is maybe making you not feel very good from a performance, a movement standpoint, and that side of the back pain. And I'm going to treat the things and I'm going to see how they change. But at the same time, I said, I want you to monitor these physiological symptoms. And ideally, they start to feel better as we treat where your body's directing me, as we make things happier, as we start knocking out, checking the boxes of all this mechanical stuff. We'll have a concurrent improvement of these physiological symptoms. However, if we do not, I was like, I would like to potentially think about referring you to a pelvic physical therapist or a urologist or some sort of doc, we need to maybe do a little bit further workup. But right now, I'm not going to jump the gun. Nothing is like emergency level of physiological effect. But I was like, these are not ideal and could be connected to what's going on. And so it was just a really good example of like, oh, okay, this is going to take us down a little bit different road potentially than just back pain. Now, what I wanted to then talk about is yeah, okay, so what? So here's the, I want to present the case. That's kind of the backstory. He's also complains of knee pain, which visceral referral for knee pain is the kidneys. So I'm going to have Joe link in the show notes the episode on the kidneys and the episode called Pain on the Sacrum, because these both really relate to this, obviously, this case. And those are the ones that I said that I had recorded in 2024. But anyways, so do the LTAP. It directs me to the right lower leg, proximal tib fib anterior compartment area. And which is a big neurovascular entrapment. Interesting enough, the proximal tib fib joint is a osteoarticular fixation that often comes with urogenital symptoms. So that tracks. So I treat there first, and a couple other spots in his low leg. And then that improved the part of the locator test assessment protocol that was directing me there. So I retested some of the orthopedic things that were off. His hip mobility, though he can easily, comfortably sit in a full deep squat, his hip mobility was limited on that side in hip flexion and hip internal rotation. His tibia was limited in internal rotation, and his ankle was limited in dorsiflexion. And he has significant bilateral actual neural tension in a slump test. And then in the prone knee bend, which is the femoral nerve, Liseg's test, he had quite a bit of tension there at about 90 degrees of knee flexion and prone. So I treated that lower leg area and then retested and improved his hip flexion quite a bit. Still was a little restricted. Improved his internal rotation quite a bit. Still a little restricted. Normalized his dorsiflexion. Improved his tibial internal rotation, and actually helped his femoral nerve tension quite a bit. Did not retest the slump test at that point. Then retested the locator test assessment protocol. And this time, his test took me to his central nervous system. So he did indeed have a central nervous system tension pattern also on the right side. So I treated that with neural manipulation and then retested some of the things. And again, improved hip flexion, improved hip internal rotation, decreased femoral nerve tension, retested the slump test, and it was a little better bilaterally, but not still, I didn't love that. Still not as much. And interesting enough, on his slump test, he actually gets anterior hip pain on this so a very abnormal neurodynamic test, but fits the symptoms, right? Because if we look at kidney, if we look at urogenital organs, one of the complaints often is anterior hip pain, along with the knee pain. And actually, on one side of the slump test, he had pain in his knee with it too. So, very interesting. So then, third time around, LTAP did not direct me anywhere, meaning that LTAP presented that there was not a protection pattern. And so then it's like, okay, cool. Now I can treat wherever I want in terms of there's still work to do, right? So sometimes students, when they go through the LTAP course, they get to this spot where the body is like not directing you somewhere and they're like, I don't know what to do. And I'm like, this is what you would normally do then, right? Like, go back to what is your index of suspicion and what are the other objective dysfunctions that you want to improve. My index of suspicion is that there is a visceral piece because of this pain on his sacrum. And then some of the other objective dysfunctions that I wanted to improve upon was some lumbar stiffness in like L2, L1, kind of the upper thoracolumbar junction area. And then when I just listened locally to the viscera, I got a very strong listening to his right ureter. And that made so much sense with his history of passing the stone. What I wonder is when he passed the stone, right, he caused some damage to that ureter and the body is not very happy. So then I was able to add on my visceral skills and listen more specifically to the kidney, test the mobility of the kidney, test the motility of the kidney, check the pulses, treat the fascial containers, right? The fascia tolt and the general peritoneum. I connected, I treated the ureter via a kidney and bladder technique. It made quite a bit of change in the listening to the ureter, and then in the mobility of the kidney, in the mobility of the bladder, and in the SI joint, and sacrum mobility in general. And so, that was a really interesting feeling, and then I had his mobility, all the things, or all the orthopedic things that I was looking for, improved hip flexion, improved hip internal rotation, improved tibial internal rotation, improved ankle dorsiflexion, improved prone knee bend. Slump test was still a little more restricted than I would like, but improved. Instead of hip flexor pain and knee pain during the slump test, he was just feeling just normal neurodynamic tension, which is more like hamstring and just limited mobility. So that was improved, but still like significantly something. And then his discomfort, he really kind of was feeling it, this like achiness in the area of his lower back sacrum area, down in a squat. And that got a little bit better. He definitely felt like the squat felt better, easier to get in and out of from all the mobility changes in his lower extremity. But the achiness still remained. And I was like, let's see what your body does with this. I was like, I've done a lot. Now I've done a lot. Now where I'm encroaching on territory of like doing a little too much if I want the body to help me out. And so I was like, we've done enough. We did 2 rounds of the LTAP and then like some very specific visceral work. And I gave him some take home for it to support all of those things. So I gave him Corgis ball to do sideline visceral massage for the right side Tolt's fascia, colon, to kind of slack the area of the fascial container there on the right side to support that ureter and the kidney and the bladder. I gave him anterior compartment of his leg. I gave him, because that relates to the urogenital organs. And then I gave him the pain on the sacrum video, which has like sacral float and the pelvic clock exercises in. And then he was telling me some of the stuff he'd been doing on his own, which was using like a really hard massage tool on his kidney area and in his hip flexor area. And I was like, ooh, please throw that away. And here's some videos of using the soft balls in those areas that are going to be much better for you. And so I gave him some other stuff like that too. He is a very has a lot of free time on his hands right now for the next 4 weeks. And so I could tell too, he is really into learning about his body, learning about movement, doing things right. Very, he's like a breath work guy and does all the things. And so I gave him way more videos and information than I would normally give a client. But that's also because I was like, listen, there's going to be a lot of things that we can do supportive in a less forceful way than you're used to. And I want to expose you to that. So I gave him embodied viscoelastic breathing into the kidney. I gave him the entire kidney regen session, which I'll have a Joe link in the show notes. And so I'm just like, let's see if we can make this kidney happier. And I have a feeling not sticking a hard massage tool psoas thingy in it is going to make it feel much better too. But I'm really curious to see how he feels. And I told him the homework was, one, just pay attention to how he feels in the next few days. And, try these new approached self-massage in these areas around the trunk, around the kidneys, around the pelvic bowl. And then also pay attention to the physiological things, the incontinence, the erectile stuff. I want to know if, and the numbness, the sensory changes in his pelvic area, upper leg area. I want to know if those start to change a little bit too. So, super interesting case. And I wish sometimes when I shared these cases, I'm like, oh, I wish you could have felt what I felt in my hands when I was connected in the ureter, because I was like, oof, this is a very unhappy ureter. And so, that's it. Short case, but a reminder that, one, have somebody point to where they hurt, because they don't know the anatomy very well. And they just think their low back is the lower part of their trunk. And the more specific you can get on where they're feeling it, sometimes it changes the entire sequencing of questions that you're going to ask somebody, because it gives you a different index of suspicion in your brain. And that is really important. Having an index of suspicion is so important to guide you in the data that you're collecting in their body, the data that you're collecting in their subjective history, as well as when you get to the point of the LTAP, when the LTAP's great, you've eliminated the protection patterns. Now what? You have a plan of what you're trying to do and what you're trying to support. So, super great case to share. And hopefully when I see him again, I'll have a good update. And and this is what I tell patients too. I have no way of knowing if my index of suspicion was correct or not. I have no way of knowing, especially a patient like that, which is I shifted all the objective dysfunctions that I think are going to help, but he still felt the achiness, and he's I can't test some of the physiological symptoms just right there in that moment. So it's okay, I think I've shifted the needle enough. We'll know in the next 3 to 5 days of how you feel, if I really did or not. And then when you come in for the next session, we'll either continue along on this index of suspicion, or we'll change it up, find a different index of suspicion, find it, have different information, which then that's what I encourage them to do is you need to communicate with me. And then you also need to know that whether your symptoms get better, don't change at all, or get worse, all of that is really good information. I was so don't ever feel bad about telling me when something's worse or doesn't change. I don't take it personally. It's good information for us for our next visit to decide, do we need to change our index of suspicion or not? Did we do what we thought we did? And should we proceed, or should we take another look? take another deep dive, right? This is the process of combining a more specific assessment like the LTAP and then my other assessment tools with an index of suspicion, asking the right questions. All of this relates to how we get to be able to guarantee the results in 1 to 3 visits. It's not just that I'm treating where the body wants me to treat. I'm treating where the body wants me to treat in the sequence it wants within this index of suspicion based still on what brings them in. Like what is their problem, right? So everything we've learned as a clinician, we're just putting it all together in a thoughtful way. So hopefully this like hammers home a few points for you. But happy to share it. Thank you for being here. We'll see you next time.